Now it's time for the sponsor perspective portion of our program. Welcome Debra Barrett, Vice President of Corporate Affairs at Otsuka, in conversation with Dr. John Kraus, Otsuka's Chief Medical Officer.
Good morning, and thank you for being here today for what we feel is such an important initiative. As Sarah mentioned, I'm Debra Barrett. I'm the Vice President of Corporate Affairs at Otsuka, and I'm really pleased to be here with my colleague and friend, Dr. John Kraus, who's our Executive Vice President and our Chief Medical Officer. It's hard to listen to Congresswoman Sanchez and not realize how important it is that we have policymakers who also have personal experience and can look at these issues from both of those perspectives. So we're lucky to have her today, and everyone else who's on the agenda. As was mentioned earlier, each day, John, millions of Americans, caregivers, and the system are impacted by Alzheimer's disease. We know that this condition is cruel and it is debilitating for the patients who are dealing with it, as well as those who love them and are taking care of them. In addition to the devastating toll of the progression of Alzheimer's disease, there are a number of behavioral symptoms that are unfortunately not well understood. Today, we wanted to focus with you a little bit on one that is not well understood, but unfortunately all too common, and that is agitation associated with dementia due to Alzheimer's disease. Can you just start by helping us understand a little bit more about agitation, how it manifests, and what people should be looking out for?
Sure. And just before we start, make a couple of points. All of you in the audience are here because of this devastating nature of this disease. When we think about Alzheimer's, we often think of memory loss, cognitive decline. And obviously, that's a key part of the disease. But what we also see are a number of related symptoms at different times of the disease. We call these neuropsychiatric or behavioral type symptoms. This can be things from apathy, which is like disengagement, lack of interest, depression, so sad mood, to agitation, which we'll talk a little bit about today. When we think about the number of patients with Alzheimer's disease over 65, we're talking more than 6 million people. About half of them, during the course of their disease, will experience symptoms of agitation. So what does that really mean? There are kind of 3 core clusters. One, think about excessive motor behavior, so wandering, pacing, repetitive movements. 2 are physical aggression. This can be hitting. This could be property destruction, things of that nature. And 3rd are verbal aggression or behaviors. So this can be cursing, yelling, screaming, things of that nature. And you can imagine how troubling these symptoms can be to the patient, to the caregiver. And I think many of us who have personal experience with Alzheimer's disease have experienced this as well with their loved ones over time. And it can lead to poor outcomes for those patients with those symptoms, and also contribute to that caregiver burden.
John, let me touch on the caregiver piece, because at Otsuka we've heard over the past several months some really powerful accounts from caregivers and their own experiences. Can you talk a little bit more about what the impact is on quality of life for the patient and the caregiver in these situations?
Sure. And by its nature, Alzheimer's disease really is a disease that involves more than the patient. Most diseases do. But in this case, as cognitive decline, abilities decline, there needs to be more oversight and care. With symptoms of agitation, this actually becomes even more difficult to handle for families and staff for these patients. For a caregiver, it can add additional 20 hours of extra work during the course of a week.
Which they don't have, an extra 20 hours.
Most people don't have an extra 20 hours, yes. It's true. And it can actually, patients with dementia, their caregivers, usually can suffer twice the rate of emotional, physical and financial issues. So it's really very important. And I think also it can lead to changes in where care is given. My own grandfather, who was physically very healthy, very quiet gentleman, introvert, when he developed Alzheimer's, I was really shocked to hear some of the language that came out of his mouth. I was sitting with my grandmother. He ran out of the house. I had to walk around the block, bring him in. She could not care for him at home anymore. So he had to go into a nursing home, where he was for quite a number of years, actually. So it's trying to maintain that level of care can be quite difficult and sometimes isolating, because these symptoms can be embarrassing to talk about with a doctor or with other family members. Because some of the behaviors can be quite uncomfortable to describe, and they are very different than what came before the disease.
And then maybe you lose, as you said, the opportunity to keep your loved one at home as a result of this. And we could talk for a long time about this, but just now that we have a little better sense of what patients and caregivers are facing, can you tell us a little bit about the current treatment landscape and how we're addressing this issue?
So it's very important when we think about treating behavioral issues in general that non-drug or non-pharmacological interventions are very important. This can include keeping a very consistent environment, having the appropriate lighting, have things in the place where the person is familiar with. It can involve other sorts of services, recreational therapy, music therapy, etc. However, sometimes these behaviors are quite difficult to manage with the environmental or non-pharmacological means. Until very recently, most of the treatment with medicines has been off-label. And unfortunately, some of those are really kind of leveraging side effects of drugs rather than the effect of the drug. So sedation, which is not necessarily a good thing in an elderly population where falls and lightheadedness can occur. So there has been recently treatments approved for agitation associated with dementia and Alzheimer's disease. There are a number of treatments still in investigation in clinical trials right now as well. So there are attention being paid to these sorts of symptoms, in addition to the important disease-modifying work that was alluded to earlier.
So this is sort of a promising time in this area.
Well, it is a very promising time. It's the first time in this kind of last year and a half or so since the acetylcholinesterase inhibitors or the donepezil-type drugs, we actually have new treatments approved for the disease as well as for symptoms associated with the disease.
It's very, very exciting. You know, Bob mentioned earlier in the conversation that, of course, it's about having options and then it's about having access to those options. Can you talk to us a little bit from your perspective about, are there current barriers or obstacles, and how do we want to think about that?
Yeah, I think one thing to think about is when we're thinking about policy, policy should be driven by the data, by the science. Currently, CMS, and I think reasonably appropriately so, has had an eye on antipsychotic use in nursing homes. This is part of the so-called star ratings for those nursing homes. However, as we have new treatments that are shown to be safe and effective, that are approved by FDA, we need to make room in the policy for appropriate treatment of symptoms of the disease, as well as we talked about earlier, some of the underlying biology of the disease.
So policy needs to prevent inappropriate use, but also support and enable appropriate use. And that's always that balance that we struggle with in the policy world, finding kind of where is that right piece. I know we're towards the end because we have a wonderful panel that we want to hear from. But, John, given today's audience, both here and those who are watching, advocates, policymakers, people who have worked very long and hard on these issues, what do you think can be done? What would you say? What would you leave people with to ensure that patients have access to the treatments that they need?
A couple of things. Like I said, the policy should follow the data and the science, particularly when it comes to medical care. That's one aspect of it. I think the other aspect is also for caregivers, patients and their families to be able to advocate for their needs and to be able to feel comfortable about talking about all aspects of the disease with their care providers. Given our kind of system of healthcare and the limited time patients have with providers, you often won't be asked about these other symptoms. The detail may not be there, so at some level you also have to advocate for yourself.
So learn as much as you can.
Yes.
Consult your HCP and ask all of the questions, and maybe you turn to a caregiver who can help you with that, and support the wonderful advocacy work that's already going on and we hope to see more of.
Absolutely.
That's
yes.
great.
Thanks.
Thank you. All right, thanks
Thank you.
everybody.